Hello, this is Dr. Renee Wally, and I am a program director for a medical laboratory technology program. And I made this presentation for student nurses in hopes that nurses and laboratory professionals can communicate better before an emergency situation arises during a hospital situation. And this is just a general overview of everything that goes on in the clinical laboratory behind the closed doors and the different people that work in the clinical laboratory. At the end of this presentation, I would like for you to be able to name at least 3 different jobs within the clinical lab, define and discuss specimen integrity, and explain the blood bank specimen labeling procedures and blood issuing procedures. Also, I would like for you to be able to estimate the time from microbiology culture collection through organism identification and finally antibiotic sensitivity reports. In my past experience working in the clinical lab, I saw a lot of confused nurses and physicians that came into the lab. And the general public don't really know what happens in the lab, and they don't know what happens to all that blood that gets collected at the doctor's office or at the bedside. So who exactly is behind those closed doors? So the first line of employees that people see that work in the lab are the phlebotomist. They are usually at least have a high school education, and they go out and they collect blood samples. Then next in the lab, we can have tech assistants. Those students may have a high school diploma or an associate's degree in something general, or even sometimes biology majors from a university or college that can't get a job with their biology degree can be tech assistants, and those are the ones that would process in the samples that the phlebotomist and nurses and physicians send up to the lab. The next level of professional in the laboratory is the medical laboratory technician. These students are equivalent education-wise to associate degree nurses. There's a 2-year associate's degree and a 2-year program that those students go through. And at the end of that 2 years, they can sit for the American Society for Clinical Pathologists board exam, and they become board certified. Then the next level is the medical laboratory scientist. Those are the students or graduates that have a 4-year bachelor's degree. And at the end of those 4 years and clinicals, they take another board exam. And the medical laboratory technicians also do a clinical rotation, and it's usually hundreds of hours depending on the state and the program. There are also histotechnologists that work back in anatomical pathology, and those are the people that process tissue samples, and they slice them and fix them to slides, and they pass them on to pathologists so they can determine then who has cancer and if they got the margins from a cancerous tumor, that type thing. And then the pathologists are actually medical doctors that have been through 4 years of medical school and then an extensive residency. And they are generally the medical directors of all the laboratories in the hospitals and eventually clinics. So who works in the lab? Who will you see when you walk through the doors? We are, as laboratory professionals, the MLTs and MLSs, that's the medical laboratory technicians and medical laboratory scientists, we are in general quiet people that we want to help people, and we like science, but we don't necessarily want to talk or touch to the patient. So we are educated and smart, but we are not the most friendly bunch. So there's also an aging population in the laboratory. A lot of medical laboratory technicians and scientists will be retiring in the next 5 to 10 years. We're usually a pretty nice bunch, but also in every bunch, you're going to have that wicked witch of the West. Please, you will run into this person in the lab, but don't let them deter you from asking questions and figuring out what the best procedure is. We are very detail-oriented people. Everything that we do has a procedure and a policy, And every specimen we realize is a patient. It's somebody's mother, father, son, or daughter. Even though we may not act like it, we know it when you bring us those samples into the lab. And we are on your team, and please ask us questions if there's ever any doubt of what the proper policy or procedure is. So the first thing to talk about is that for your patients to get accurate results, we have to get an accurate specimen. An order of draw is very important. And you can't just pour one color top tube into another color top tube. And it does mean more than what department it goes to. So here's the order of draw. If you're ever required to collect blood cultures, those have to be done first, and then next would be the sodium citrate tube. That's for coagulation testing. And as soon as these tubes get drawn, they need to be inverted 3 to 4 times. And at the bottom of this page that I got from BD, inversion is just is the way to mix. We don't need you to shake it or mix it really quickly, because that's going to cause bubbles and hemolysis, which means lysing or breaking apart of the red blood cells. And I'll explain more about why that's important in a minute. Next would be the serum tubes. That would be the red top or the gold. Then next would be green heparin tubes, and then EDTA tubes, and then some extra things. And then lastly, the fluoride tube, the sodium fluoride tube, that would be for glucose that needs to sit at a clinic or something before you send it to the lab. And just as a side note, there is a difference between serum and plasma. Plasma is the liquid portion of blood that contains all the proteins, antibodies, things like that, in addition to coagulation factors. In serum, the blood has clotted and there are no coagulation factors in serum. So that's the difference between plasma and serum. So again, plasma has all the proteins, including coagulation factors, and serum is the liquid portion of blood that does not contain clotting factors. The blood bank tube it's especially important to label it just perfectly. And this is not dictated by each individual lab. These policies and procedures come directly from the American Association of Blood Bank, which governs the procedures used in the blood banks in the United States. And also we are inspected by the FDA, because it's a substance that's going into a human body. That's why we fall under the purview of the FDA. So every blood bank tube needs to have the patient's complete name, first and last, no nicknames, the medical record number or a billing account number or social security number, the date of collection, the time of collection, and the identifier of whoever collected that sample. Now, we realize in the lab that there are emergency situations, and there will be a need for a mass transfusion protocol that you may see referred to as MTP, or times when we need to emergency release O-negative units. But still, we need some type of label or some identification so that later on, when the emergency has passed, that we can do proper testing on the patient and the unit of blood that was issued. And I'll come back and talk about that again later when I get into the next portion of the talk. Labeling, first of all, you have to label, or anyone that brings a sample to the lab has to label the sample. And if we get a sample that's not labeled, we have to throw it away. We don't enjoy that, but we can't turn out a result when we're not sure that the person that drew it is sure who the patient is, because we don't want to turn out incorrect results on any incorrect patients. And labels matter. We don't mean to be sticklers or picky about everything, but these barcodes and labels that go on every tube, they tell the machine what test is done, who the patient is, and eventually it'll tell us where the tube is stored. but the barcode reader in the machine is just like the one at the grocery store. So when you scan the barcode on the sample, it needs to be at an angle and in orientation so that it can be read. So the machine can't scan wrinkled tubes, or if you have a small PD tube that's been collected, please don't crinkle it up so that it looks like it's wearing a turtleneck. One label doesn't need to go around 3 different tubes. Each one needs their own label. The label basically needs to be with the name near the top so that the name is down the side of the tube, and then the barcode is straight. And also, it's very important that you leave the opening in the back, that the person collecting leaves the opening in the back, because we can quickly see if a sample is hemolyzed, or we're going to talk in a minute about the fill line on certain tubes for certain tests, and that's very important. And if it's not, if there's something wrong, we can easily see it. And if it's not like that, then we have to peel the tubes off, and we're wearing gloves, and it just delays the results just a little bit. All right, next. So this is what, I know this is not labeled. I took this picture in my lab for to illustrate this point, but here's a nice urine sample with the lid on. It's been collected. This makes us happy when we get this in the lab. But a lot of samples get to the lab through the pneumatic tube system. So imagine that you're in the ER and you've just put this patient's urine sample into the pneumatic tube, and then when we get it into the lab, it looks like this. You can see that the urine has spilled out, the lid was not on securely, so it's lopsided, and we can use this sample for a urinalysis, but this is no longer sterile. Inside the cup was sterile, but the bag is not sterile, and so there could have been transfer of urine from the bag to the urine, so we can't use it for a culture anymore. And this makes us very sad. And it delays things quite a bit. And also, an experience that I had was I called down to the ER, and I said, hey, these urines are coming up to the lab and the cap's not on good and they're leaking. So the next urine that I got, the lid was on so tight, I felt like I need to call Superman to unscrew it. So we don't call down and tell you things like that to make your life more complicated, but it's faster for the patient, and it can end up being a safety risk. So before any tests can be run in the lab, there are some things, a lot of things that are happening. And I'm telling you about this today because sometimes nurses and physicians will call the lab and they will ask, where are my results? And I want you to understand what some of our responses mean. Now, we realize that you need your patient results, and it's very important to us as well. We have a pending list, and we can see everything that's coming in, and we can tell if we're getting behind or if a patient's result is taking too long. It starts to turn red and flash at us. And just as much as you want your results, we want to give them to you. But there are sometimes when, before any tests can be run for the day, every 24 hours, we have to run quality control that we call QC. We have to do maintenance on all our instruments to make sure that they're working properly. And there are some other things that we're going to talk about that's going on. So pre-analytical testing, this is the things that happen before testing. So sample collection is definitely a part of pre-analytical testing. This is also known as what is taking my results so long. We know in the lab that nurses and physicians get very exasperated waiting for their samples sometime. But remember, specimen integrity matters a lot. Now, if you are a nurse or a physician and you work for any length of time, you are going to get a call from the lab that says, I'm sorry, we can't run this sample because it is hemolyzed. I just want you to know that we do not hemolyze it in the lab. It can be there are different things that can cause hemolysis. And the reason that we can't accept or result specimens that are hemolyzed is because especially potassium and lactate dehydrogenase, or LDH, the concentration inside the red cells is so much higher than outside the red cells. If there's any hemolysis, red blood cells have ruptured, releasing extra potassium. So those results are not valid on a hemolyzed sample. Also, the results that can be affected by hemolysis, the CBC, the complete blood count, the iron, the ALT, the liver enzyme, some thyroid testing, and slightly phosphorus total protein. But the main thing that's affected is potassium. We cannot result that on hemolyzed samples. Causes of specimen hemolysis: using a needle that is too fine, excessive aspiration or force if you're collecting blood from a syringe, forcing blood into a collection tube. All these collection tubes that we've seen so far, they have a slight vacuum, and so they will fill naturally and stop at the point that they need to. Also, shaking and vigorous mixing. Don't shake. Remember, you just need to invert the sample tube a couple of times. Also, milking a patient's arm, that could cause hemolysis, and also premature or excessive centrifugation. So now I'm going to tell you that we prefer, especially in the chemistry lab, we prefer to use plasma for testing because you're going to send your samples to the lab, and if you are sent a tube that's a red top or a gold top, we have to wait 10 minutes for that blood to clot so we can centrifuge it and use the serum. So if we are using plasma, which is not going to clot, we can go ahead and centrifuge that for 3 minutes right when it gets to the lab. So it saves a little time. Also, especially babies and complete blood counts. Babies are notorious for clotting. So if you ever have to collect a baby or a heel stick for any reason, make sure that you invert that quickly. And sometimes it's not even going to be the phlebotomist's fault or whoever collected the sample, because some patients just tend to clot. But this is a purple top, an EDTA tube that was sent to the lab for a complete blood count. And if we have a clot in the complete blood count, that means that the platelets and clotting factors are already tied up into the clot. Also, some of the red blood cells and white blood cells. So that is going to affect your red blood cell count, your white blood cell count, big time your platelet count, and also your red blood cell indices like your MCV, mean cell volume, and MCH, mean cell corpuscular hemoglobin concentration. But especially, we cannot run any coagulation testing like the PT or the PTT if there are clots in the sample. So we will have to call for recollects. But remember, we don't like calling you any more than you like having to recollect samples. So the causes of clotted samples: leaving blood in a syringe too long before it gets put in tubes, if a patient takes a really long time to draw, and improper mixing of anticoagulated tubes. Now the blue tops that go to coagulation, these are very special. They contain a certain amount of anticoagulant in every tube. So if you ever pick up a tube and have to look in it, especially if it's a purple top, you'll notice that it looks kind of sandy or gritty, or maybe even you see a little drop or two of liquid. That's supposed to be in there. That is the sodium citrate anticoagulant that keeps the whole blood from clotting. And there will be an indicator on the blue tube that tells you how much sample we need. And that's very important because there's a set ratio of anticoagulant to blood in the blue top tube. And if that ratio is off, your coagulation test results will be off. And that could cause your patient to get different Coumadin or heparin or anticoagulation therapy, and that could be really bad for your patient. So those lines are very important. So look for that, especially on the blue top tube. Also, if you are collecting a blue top tube and that's the only thing that you're collecting, you should draw a little bit of waste in a tube before you actually collect the sample that's going to be tested. Sometimes tests require special conditions, such as bilirubin. In babies, especially, we require that to be collected in an amber tube because bilirubin is broken down light. And we ask that needles be removed from syringes if they're sent to the lab for blood gases, arterial or venous. And this would be if you need to send a specimen on ice, it's just a cup of ice, and that keeps it a little chilled. Things like, for an example, the ammonia level. That's collected usually in a green top tube, and it's going to be transported to the lab on ice immediately. All right, so the samples have been collected. What happens? So the samples, a lot of them come to the lab through the pneumatic tube system. Once they're received in the lab, they get centrifuged for about 3 to 5 minutes, depending on the test. And then some hospitals, you may see a track system. So this is a lot of blood, but the track system can send it to the different departments. But in the smaller hospitals, people have to walk it to the department. All right, so we also have to calibrate our machines. And I'm explaining this because sometimes we'll call the lab, or the nurses will call the lab and say, I need that glucose result. And we'll say, we're having to do a dilution, it's too high. And I've had a nurse or nurses before say, well, can you just give me a number? Well, no, I can't just give a number because I have to do a dilution. And I want to explain why we have to do a dilution. We have a calibration curve. So we have these 5 levels that come from a company that we know the concentration. So they would be from usually 50 to maybe 600 milligrams. So one sample would be 50 milligrams per deciliter, one would be 150 milligrams per deciliter, etc. So this means that our instrument, chemistry analyzer that runs the glucose, is only valid for glucose ranges or glucose values between 50 and 600. So let's say that your patient glucose ran greater than 600, or even maybe it gave me a number of 720. Legally, and according to policy and procedure, I cannot result that 720 because it is past the highest calibration that my instrument is calibrated to read. So then I would have to do maybe a ×2 dilution, and let's say that time I did it, I ran it, and it read 350, but I had made a 1:2 dilution. So then I can turn out your glucose value or the patient's glucose value as beyond 600. So I know that's a little confusing, but if anybody wants to talk about that or ask questions, my email information is at the end. And this calibration has to be done for every test that we run in the lab, every single one. And this takes time. Luckily for most things, they only have to be calibrated once a month or sometimes even once a quarter when we change lot numbers. The next thing that's going on in the lab that might delay your results is daily maintenance. Every instrument and analyzer in the lab, the technicians and technologists have to check the probes and the tubes, all this stuff, empty the waste, change reagents every day. Also, temperatures have to be checked in the instrument, in our refrigerators. So that's another thing that we do. Also, every day, twice a day at a minimum, we have to run 2 levels of quality control material, and that's to do 3 things. That's to make sure that the instrument is running properly. That's to make sure that the reagents that we are using are good. And that's to make sure that the technician or technologist performing the test are performing everything correctly. So for every test that is done in the lab, we have 2 levels of control. So this would be the glucose control, There's lipid control, drugs of abuse controls, coagulation controls, body fluid controls, urine controls, hematology controls, and a whole special rack of controls just for blood bank. Now, every one of those tests has to be done twice a day. Usually, labs pick maybe 7 a.m. and 7 p.m., something like that, so that one shift runs one and the other shift runs the other. But if those controls are not in range, we have to stop patient testing and figure out what the problem is. And that's how we ensure every day that our patient results are accurate and precise. And we are looking at our quality control. This is just an example of the cholesterol controls that were run every day for a month. And see this red dot right here? That means one of our controls was out of range. So before we could continue for the day, we would have to figure out what's going on with cholesterol. Is it a bad reagent? Is the temperature too hot in the machine or something? Or did the technologist mix up controls wrong or do something? So we have to investigate that. And of course, one does not simply get through a quality control run without having some kind of an issue, and it's very exhausting. So, we are finally finished with pre-analytical testing. So that's it. Now we're ready to talk about analytical testing, and we are ready to run our samples. Ready to run. So in hematology, this is where the purple top tube gets sent that we hope doesn't have any clots and is not hemolyzed. And this is where your white blood cell counts come from, your red cell counts, hemoglobin, hematocrit, and also will tell you how many neutrophils, lymphocytes are in every patient. And this is the first place that we would see things like leukemias, malaria. Those are just some interesting diseases that we would see. So a lot of times the instrument can do a automated differential, and that's what this is here. It gives you your neutrophils, lymphocytes, monocytes, eosinophils, basophils, if there are any nucleated red cells, and it comes out in a scatter plot like this that we see in the lab that doesn't get resulted to the floor. But if there was something not quite right in here, something a little out of range, we would have to do a manual differential. So sometimes your white blood cell differentials will be delayed just a little bit because a human has to actually look at it. And the process involved in that is we take one drop of blood from that purple top tube and we make a smear on glass slides so we can stain it and look for cellular structures. So what a white blood cell differential is that we are actually looking in the microscope and we are counting the first 100 white blood cells that we see. So this would be red cell. We're also looking at red blood cells for morphology, like are there microcytes, macrocytes? Is the patient anemic? If they have a low hematocrit and hemoglobin, and decreased red blood cells, we would need to know if their red blood cells are small or big, and that's going to indicate what kind of anemia that they have. And these little purple dots are the platelets. We need to make sure that there are no clumps, and we're looking for normal, healthy white blood cells. So this would be an example of what would happen if our sample has platelet clumps. Sometimes there are micro clumps or microclots within the tube, and we may not see that until we make a manual differential. This is an interesting slide of what an acute lymphocytic leukemia looks like. There are all these purple dots. Those are 100% lymphocytes. And then this is sickle cell anemia. So there's some sickle cells and target cells, and if you notice they're kind of bluish colored, that means that they're immature. Also in hematology, they do the body fluid processing. So when we get some spinal fluid, there's usually 4 tubes that we get, and we load an instrument called a hemocytometer. And this is a picture of what the red cells and white cells would look like in our spinal fluid. So we actually count, like this would be a white blood cell, these are red cells, white blood cell, white blood cell, white blood cell right there. So we have to look at that and count how many white blood cells we see and sometimes how many red blood cells we see so we can report that to the physician. In coagulation, this is where we do the PT, the PTTs, and the D-dimers. And again, this is very important that the blue top tubes are filled just perfectly. We do urinalysis. Sometimes hospitals may have the old chemical dipsticks like you may have used in your classes, but there are also analyzers that will test things for us. And we are looking for white cells and bacteria, epithelial cells. We can see trichomonas and sometimes different kinds of crystals in the blood. In the blood bank, this is a very important area. Lab techs in the blood bank determine what a patient's blood type is, but more importantly, what kind of compatible cross match. That's what we do, cross matches. So, what is exactly a cross match? So, a sick patient comes in and it's determined that they need blood or packed red blood cells. So, we collect a blood bank specimen. This one would not be acceptable because it is not labeled. Then we centrifuge that so that we have red blood cells to work with and some plasma. We would do a type on the patient so we know what type the patient is. And we would get then a blood bank donor unit of the compatible type. And these things up here, those are segments. It's kind of like a seal-a-meal type thing. If you've seen it, there's a little bit of blood sealed off in every one of those segments. So we take one of those segments, and what we do is we take the patient's plasma and put that in a tube, and we take red blood cells from the unit and we put that in the tube with the patient's plasma, and we incubate it at 37 degrees Celsius, which is body temperature, and we see if the red blood cells lyse or if there's any clotting or agglutination. And that's how we determine if a patient unit is compatible. And this takes time. And that's only if everything goes perfectly. Sometimes patients have unexpected antibodies, and that takes some time to figure it up, especially if you have like a sickle cell patient that's getting a lot of transfusions. Sometimes those patients can have so many antibodies that we have to special order blood from a blood bank, something like the American Red Cross or the Blood Center in New Orleans, and it could take days to weeks sometimes to find a compatible unit or units. Issuing blood is something that's one of the most common areas where lab and nurses have interaction, which is what sparked my interest in doing this presentation, because this is where miscommunication happens. And I want you to know ahead of time that we have a policy and procedure, again, that's governed not by each individual lab, but by the FDA and the American Association of Blood Banking. So whoever's going to come pick up the unit needs to bring written documentation with 2 patient identifiers, and the room number is never a patient identifier that is acceptable. You will either be asked to read the information on the unit to the tech and they will read it back to you, or the laboratory tech will read it to you and you read it back to them. We will need a sign out date and time and name for the person that took the unit. The paperwork always stays with the unit, and remember, we're inspected by the FDA and we have to follow these AABB procedures. So the blood needs to remain refrigerated. If you're not going to use it immediately, you can bring it back to the blood bank. But it has to be returned, I think, within 30 minutes or pretty quickly. If it's out of the refrigerator for more than so long, like 30 minutes, we can't even use it. We have to throw it away. Please stay off your phone and don't bring food or snacks into the lab. And if I'm having to say that, that must be somebody did it before. Ask questions before you leave the blood bank, and we appreciate, we enjoy explaining what we do. But again, I want y'all to know, whoever's listening to this, is that I'm giving you this information to prevent high stress areas in high stress situations in already stressful situations. We also do cord blood testing. We get the cord blood and we test it to make sure that there hasn't been a maternal fetal bleed and the baby doesn't have hemolytic disease of the newborn. The next section is microbiology. When you're collecting cultures, especially things like throat cultures, you need to make sure and go right for the infected area and send that to the lab. We also will be happy to take your stool samples and, of course, your urine samples. So when we get sputum samples, those take a little while, and you may get a phone call one day that says the sputum is not acceptable for culture, that we had to reject it. And what that means is that it was just spit. And this is how we tell the difference between sputum and spit. So a sputum sample has more white blood cells. All these pink things over here on the left, those are white blood cells. And these purple things, these are gram-positive cocci. So there are way more white blood cells than epithelial cells, which I don't see any epithelial cells over here. Whereas this picture on the right that is just spit, because there are mostly epithelial cells, I don't see any white cells and a whole bunch of bacteria. So this would not be a sputum sample, and we would not be to culture that because all you would get would be normal flora. We also use all kind of different media in microbiology, but the most important thing to know is that it takes time to get your identification and sensitivity. So we get your culture, we set it up on one of those media, then we put it in the incubator for 12 to 16 hours, and that takes time. Then we would look at it the next morning, and the technician in microbiology has to decide if it's a pathogen or normal flora. So this would be an example of normal flora. There's more than one bacteria in there. There's a lot of it, whereas over here, this would be this is what Streptococcus pneumoniae looks like when we grow it up in the lab. So that already took 24 hours, right? So the next step is to put our bacteria, if we don't know the definitive identification, we still have to put it on this machine. And there are different machines, but basically there are some biochemical tests up in this area with the colors. That is going to tell us what the bacteria likes to eat, things like that. And so that's going to be where we get the identification. And these down here represent different concentrations of different antibiotics. So again, this is going to go in this analyzer, and guess what? It usually takes a day or overnight to figure out the identification and the sensitivities. And then, so let's say the next morning, this is after 48 hours, we finally have an ID and a sensitivity, but sometimes with penicillin or methicillin resistance in certain organisms, we have to wait an additional 24 hours to see if it's truly methicillin or penicillin resistant. So again, we have to wait on that. Luckily, there are some new developments in the lab where we can use molecular biology. And this little contraption right here, it's about the size of a snack bag. And with this molecular equipment, you can take a nasal swab, send it to the lab, and within 3 to 4 hours, we can test for 15 of the most common respiratory bacteria and viruses, and also a few of the most common resistances, like does it have the MEK-A gene, which means that bacteria would be methicillin resistant. And not every hospital has this, but it's really new, and it is definitely the wave of the future. In chemistry, this is where we do the metabolic panels, cardiac enzymes, quantitative beta-HCGs, hemoglobin A1C, and cancer markers, and a whole lot of other stuff. Finally, you get your results. Normal values, some places are going to auto-verify, but just take note that we need to call certain critical values. We are required to call you with certain critical values. Even if we know you know already, we have to call you. And once we give you those critical values, we really don't know what to do then. That's all your job, and I'm glad, because you're the ones working with the patients. So thank you so much for listening, and I hope you find this helpful. And Please contact me if you have any questions or comments, good or bad. I would love to hear your feedback. Thank you for listening.